It's great to be here with you at GP17. Thanks so much for the opportunity to speak with you today. I was asked to speak about evidence in general practice, and when I got the call, I thought, oh, not the most exciting topic, but what could I do with that? So the first thing that came into my mind was evidence in general practice, sort of the debate that happens, cookbook medicine. That's what it is. And maybe GPs aren't that interested in it, was another thought. So what I want to do this morning, very briefly before morning tea, is to speak a few, maybe three little parts of my talk, really focusing and reflecting on this idea of evidence in general practice. And I want to begin with an afternoon in Trentham. So who of you know who's on the slide? Stephanie Alexander and Annie Smithers. I'm sure there's nodding of heads that you're familiar with them. So these are two wonderful female chefs from Melbourne. Highly recommend going to their restaurants. But I had to get my title to the college for this talk, and I was driving on a Saturday afternoon to a conversation with Annie and Stephanie, and we had tickets. It was part of a fundraising thing for Stephanie's kitchen garden. And as I was heading there, I was sort of thinking, oh, I need to get that title of the talk back to the college, what will it be? And then I sort of forgot about it. And during the afternoon, here I was privileged to just witness, about 40 or 50 people were there, these two wonderful chefs talking about what they did. And they spoke with passion about their life as a chef. Annie was an apprentice of Stephanie's back in her famous Melbourne restaurant, and you could see the connection between them. But the thing that stood out to me was the focus on ingredients, and they spoke with passion about ingredients. They grew ingredients, they were focusing on the quality, where they bought them from, how they could find better ingredients, what were the ways of putting them together, how could they perfect the poached egg, how could they perfect the mushroom dish? Simple is better, less is more. All these principles that they were talking about. And over the afternoon, I just saw so much synergy between these two passionate chefs and what I hear when I speak to GPs and when we get involved in those discussions about what we do and why we love what we do. And this idea as evidence, as an ingredient, just seemed to me to be something that might resonate with you this morning. And so I challenge the idea that the GP is, cookbook medicine, or the GP is the kitchen hand, but I think the GP really has much more akin with these very distinguished chefs and the way they go about doing their business. And I just want to follow that through a little bit more with you this morning, before morning tea, in case you get hungry. Okay. Now this quote, so at GPs, how do we use evidence? Well, I think we use it with a scientific spirit. I reject the notion that GPs are unscientific and not interested in evidence. I think we take evidence and we use a scientific spirit. And you'll see this quote from the poet, American poet Walt Whitman, and he said, I like the scientific spirit, the holding off, the being sure but not too sure, the willingness to surrender ideas when the evidence is against them. And this is ultimately fine. It always keeps the way beyond open. It always gives life, thought, affection, the whole man or woman, it's written a long time ago, a chance to try over again after a mistake, after a wrong guess. And I just thought that really is, to me, the way that we interact as GPs with the ingredient of evidence in our everyday practice. So now I just want to move a little bit to the fact that we should be celebrating the way that GPs contribute to evidence, and we do not celebrate it enough. And I suppose I'm a bit fed up of hearing from various meetings where I go to the idea that GPs won't be interested in research, they won't recruit you any patients, they won't do this, they won't do that. Well, if that's the case, why does so much research that has been generated by GPs exist? And if you're in any doubt, and if you haven't seen this wonderful book that Michael Kidd and Ione Heath put together was a brilliant idea, and it won an award recently at BMJ Awards over in the UK. And it was the idea of just putting together the classic papers from family medicine, and many of us were asked to contribute a paper, and I was really privileged to be involved in this, and I chose a paper by the wonderful Charles Bridges Webb, which many of you know, and I chose his 1972 Traralgon Health Illness Survey, one of the first epidemiological studies of the life in the community, and he was a great colleague of Julian Tudor-Hart from the UK. So wonderful papers in this, evidence galore. And I just also want to speak now a little bit more about the celebration of it, just to run through a few examples, and I know you will have more. We could fill the day with them, I'm sure. But we have a Victorian practice-based research network, VicRen. There's research networks in other states that many of you are involved in, and we can do all sorts of things, from small studies like this, about the first study ever to be published about how GPs go about managing same-day appointments. It came from one of the VicRen dinners where GPs, some of them here in the audience, were sitting around having a meal together, talking about things that mattered. And this was something that came up. And with Meredith Temple-Smith, who was supporting the network, this work was done. And it's a great piece published in our own AFP. But also we do large-scale studies, and this is a study I was involved with Jane Hocking from Population Health, and many of you will have been in this Esprit Trial. This had 150 more plus practices. GPs were involved in this chlamydia study. Whole towns of GPs were recruited. You couldn't be in this Esprit Trial unless the entire town was recruited. And many of the colleagues on this said, well, that will never work, that will never happen, it'll be a disaster because you'll never get all the GPs on board. Well, GPs came on board. Chlamydia was seen as a very important problem, and this study is ongoing, and it's one of the biggest ever done anywhere in the world. Likewise, the Ageing in General Practice study, Dimity Pond, Parker McGinn and co, 3 states of Australia, myself and Nigel Stocks involved. Once again, hundreds of GPs, thousands of patients around the important area of dementia management. The Esprit Trial, which I'm sure many of you are involved in, the study of whether aspirin prevents problems in older age. And unfortunately, well, this is a fantastic study, it was stopped in June of this year because it was looking like there was not going to be any benefit of taking aspirin. A big shock. But here, thousands of Australian patients, hundreds and hundreds of practices involved in this really landmark study led by Monash University and John McNeill. So I hope just with those examples that I've convinced you that and I'm speaking to the converted, of course, because it's all GPs like you that are involved in all of these studies. But we should celebrate this more. We are actively engaged in research and we do it every day. But I want to finish off on some challenges and things that I think, what lies ahead? And what lies ahead is the digital ingredient. And I'm sure many of you are involved in different groups and discussions about the use of our routinely collected data and what might be happening with that in the future. And it just strikes me that in the past, we have been the deliberate gatherer of evidence. We've known when we've been gathering it in particular studies, and we know what we have to do, and we fill in the forms, and they might get a bit tedious, but we do that and we know we're doing it. Well, now we're entering the era where we're gathering evidence unobtrusively. We're gathering it every time we see a patient. Well, that's what the people who want to use the data that's in the GP records think we're doing. But we actually haven't been doing that overtly up until maybe this point in time. And so now I think the big conversation we have to have is about how are we going to go about that unobtrusive gathering of this digital ingredient that is going to be the evidence of the future. So as we move, why do we want to do this? For lots of reasons. I'll just pop up the Vioxx example. It's an easy one to pull out. We know hidden within our GP records, there's lots of stuff to be learnt. Well, and there could be other medications that are causing a lot of harm. We might be collecting it all together and it might be there. all but for some kind of machine learning robot to come across it and find it. That's what we're kind of holding up as hope. So this gives us a good reason to gather the digital ingredient and have people who can understand it, to learn things for the public good. But what happens when we're all connected up in this digital web? Are we ready for it? I think we've got a really major conversation to have, and that is one where we need to think about the ingredients which we should gather. And we look at the wonderful talks we've heard this morning, and beginning with Sir Harry Burns. I mean, look, the kind of ingredients that we should be gathering in our medical records. What should we be recording if we're going to actually be contributing to the evidence that's going to make a difference? There might be new things we should be recording routinely in consultations. There might be bits that should never be shared with anybody. So this, unfortunately, in Australia, there is no legislative framework for the use of health data, routinely collected health data, and what should govern it. And this is a really big gap in our legislative framework, which we hope is going to be filled, but this data is being used already. So we could say a lot more about that, but I believe that as GPs, we use evidence as a key ingredient every single day. We use evidence with a scientific spirit. We have been in the past deliberate gatherers of evidence for all those sorts of research studies I showed you, and we are also unobtrusive gatherers of evidence. And we have been for many, many years. But the evidence we've been gathering, and as it exists currently in our medical records, may not be fit for purpose in terms of learning insights that we can really rely upon. And so what I think we need to have is a public conversation, both with ourselves and with our patients, about our role in this unobtrusive gathering of evidence and our absolute key role that we have to remain central to the way that evidence is interpreted, because we have to be key to all of those conversations, as well as relying on the mathematicians and the biostatisticians and all of our specialist colleagues. But what's hidden within our records is gold, but only if you can interpret it correctly. So I want to finish with one of my favourite pictures that was taken when I was lucky enough to be at the University of Washington in the US and visit the amazing Professor Edmund Pellegrino, who is a very famous medical ethicist who has sadly passed away since I've visited him a number of years ago. And outside the medical school there is this wonderful statue, and it's about balance. And you see this beautiful statue woman leaning across, looking at a strange ingredient. Is it an apple? Is it a tree? What is it? And to me, we were there visiting him about our work on generalism, Vicky Palmer and I, where we were talking with him about the way that the general practitioner balances both the biotechnical, the ingredients, the data hidden, the evidence that we use every day, with the biographical, the lived experience, the world of our patients, and that this is so key to the healthcare system and something we do really well in Australia. He was glowing about the role, and as we move into this digital conversation about our digital ingredients, I think we need to be there, balanced, open to looking at them and understanding what this evidence is, but absolutely central to it. Thank you.
Thank you, Jane. That was wonderful. We've got time for a few quick questions. Just letting you know that our other speakers will still be available for some more questions for those who want to stay on during the morning tea break. But first, I'd like to invite some questions for Jane.
Good morning, Jane. My name's David Adam. I'm a GP in Perth. The secondary use of data is something that, as you say, presents a real challenge for us in general practice. And I just wonder if you could make some comment on how you think that the general public perceive that and how we go about consenting people for their participation in schemes that I think Australians and people in general are fairly distrustful of in terms of the large-scale data collection by governments.
I think, I think it's a very topical issue. I've been involved in a number of committees where we've discussed this kind of thing, and on those committees there's always been consumer and carer representatives. And I would have to say that mostly, as a generalisation, the consumer representatives are wanting health information to be used for the public good. So, for example, they want things like the Vioxx issue to be avoided in the future. They want their data to be used to inform care. They want data to be used to assess whether or not people are getting the best care they can get, so that they don't want it done in a punitive way, but they really would like to see what their data contribute to things improving practice. So I think they're very open to the idea of it, but they want it done by a trustworthy source. They want it done properly. They don't want it. They want it done in a way that the answers can be believed, and they want it done securely. And they want to have a say. They want to have a say in how it's done. And so I think that one of the things that we need to focus on most importantly is about making sure that we have the safeguards in place so that data cannot be misused. But we should have to do so in a way where it is used to find the answers to the big questions, and that the consumers have to be right in that conversation. And we don't have the framework for it to be legislated. So us doing that, we need to lead, I think what was said previously about let's just do it, let's do it the right way. Let's show how to do it. If the government won't legislate, let's do it correctly, even though the legislation, we could do all sorts of things that aren't particularly that great. Let's do it, as what we have correctly, would be my response. Mm-hmm.
Hi, Jane.
Hi.
Michael Wright, I'm a GP in Sydney. I was just wondering, probably further along that line, there's talk about with reform of PIPs and practice payments, and then somehow data being potentially shared with, practice data being shared with the department. And I'm just wondering how you see that fitting within this legislative framework, or is that whole process going to be diverted by that?
I think we're in for interesting times with the QI PIP, aren't we? Where to begin? I mean, my personal view is that we should be looking after health data in an independent authority, independent of government, independent of or any vested interests, and that those people should be held accountable for the independence of it, that it should be governed properly. We can look at examples from overseas, like in Canada, where this has been done very well. We can look at Scotland. Harry must wonder what we're talking about. I mean, the Scottish are just so far ahead of us on this. All sorts of interesting things there, with people opting in and on websites and deciding what to do. The Scottish public want they want it used, and they just trust that it will be used, that it will be secure, because it is. And so I think that that independence and proper governance frameworks, and involving all the different sectors of the health professionals as well as the community, is key. And at the moment, that's not necessarily the direction that we're heading. But that's what I'd like to see, and I'd love to see the college lobby for it.
Thank
you. Hi. Sorry. A bit short, maybe I'll stand up here. Wally Jamal, GP from Western Sydney. Hi, thank you for that talk. Look, I comment maybe and would appreciate your comments on it. We in Western Sydney have actually started doing this under the coverage of ACI and New South Wales Health. Mm-hmm. We're part of a data integration project. Protected by law, I handed over our entire database and linked it to New South Wales Health data, and the results are astounding. Yep. The information that it gives us, absolutely outstanding. Like 50% of patients were admitted to hospital in the last 5 years, 50%. The patients who visited our practice more than 7 times a year had a significant reduction in ED admissions. That's the sort of stuff I think that at a population level that we need to get involved in. And I say not be afraid, But as you say, do it properly, do it with eyes wide open, and with some sort of control over it as well. And other countries are doing it, as we've seen. So appreciate your comments about that. We should actually get really involved in this.
Yeah. I agree. I think we need to embrace it, and absolutely we need to do it in a way that it's open and transparent, that it's not a punitive way of doing things. It's about continuously improving what we do. And in a way, you know, just understanding our own practice records is a bit navel-gazing, and it doesn't really give us the insights that we will get, which were just so eloquently described there by Wally, that we need to understand. And we need to be open to maybe seeing things that we aren't that proud of, but we also need to make sure that the things we're seeing we can believe. And I think that's probably why I think we have to have a lot of clinical involvement in the way that the data is interpreted and what it means. And because unfortunately our medical record systems, the EMRs that we use, are not fit for purpose either. And they aren't, you know, if you could transform it, you'd start again. But we're such a small market that probably nobody's got that much interest in it. But they're not, you know, they're all just in need of so much help in the interpretation of what comes out of them, unfortunately. I think that's it.
I think that's it.
Yep.
Yeah.
Thank you.
Thanks for the questions. Thanks, Jane, for a great presentation. Got a little gift for you.
Thank you.
Thanks very much. Yeah.